very hard for me to not think of this as a favorable risk-benefit ratio. I don't think that you can really separate efficacy data with the feasibility of delivery. And while we are looking at side effects of cumulative bone marrow toxicity, fatigue, ILD pneumonitis, this is included in the data. And despite the fact that we see these side effects occurring, we still see this tremendous progression-free survival benefit. So it's very hard for me to not think of this as a favorable risk-benefit ratio for patients. And again, it depends what the patient's outcome is. My experience is those are younger women typically, oftentimes with very little comorbidities, where efficacy and survival is really what they're asking of me. And then the discussion is very clear. We have a new standard of care by efficacy standards, which doesn't mean that THP is not a legitimate regimen for a patient that opts for a sort of a more gentle approach. But again, most of my patients tell me in their own words that efficacy is what they're aiming for, and then the answer is very clear, and there's not a lot of decision-making necessary because the trial gives us the answer.
Absolutely. And I think that we can be proactive, right, about managing the potential adverse effects. Let's talk a little bit about that. You mentioned several of the adverse effects that were noted in DESTINY-Breast09, but fortunately, we're all familiar with trastuzumab deruxtecan, and so we have effective management strategies. What is your approach to either preventing and or treating any nausea or vomiting that may be associated with T-DXd?
I think like we do with any other regimen that's highly immunogenic, I think this is probably one of our strong suits in oncology, supporting patients through GI toxicity. We use steroids, we use a long-acting NK1, we use the 5-HT3s, and then individualize it to patients' needs. I haven't found it to be a problem in my practice, so I've been very proactive about it, and I think that's how the guidelines place the regimen as well. I think there's the flip sides of having highly effective therapy that we need to deliver and supportive care at the same time, but I think that's never been an issue for us.
Yeah, absolutely, and I think that the 4-drug or even 3-drug regimen for nausea prophylaxis is incredibly effective in the same way as you alluded to that we manage nausea for other therapies like anthracyclines. Any pearls that you have about managing either fatigue or any other AEs that are commonly seen?
Yeah, fatigue is obviously more challenging, and we have to differentiate the fatigue that is related to anemia versus the fatigue that's related to and that's sort of a non-anemia related. My experience is that eventually we cut beta doses down, so the 5.4 milligram per kilogram starting dose we talked about, achieving a really deep response in the beginning, moving into a higher level of time frame where 4.4, even the 3.2 milligram per kilogram body weight dosing may be necessary. I think we strike a balance there between efficacy and safety.